Everybody. All right, we'll go ahead and get started. Welcome and thank you all for coming, everybody who's here and who's joining us on Zoom. Today we have our fourth installation of the Senior Resident Grand Rounds. I want to thank so far all of our resident speakers up to this date. It's really been wonderful, and it's going to be all the more wonderful today after Drs. Luther and Zarro present for us. I also wanted to thank Jen Bogovich and Janae Davis, who so far have been helping organize all of this. So big thank you to all of them. So we will start today first with Janki Luther. I will introduce her and Dr. Zarro, and then we'll have time for questions at the end of both talks. So Dr. Luther is originally from Massachusetts, came over to WashU for her undergraduate studies, headed back to Massachusetts for med school, and then back over here to WashU for her internal medicine residency that she's finishing up now and is currently applying for a gastroenterology fellowship. She'll be talking to us today about Medicaid expansion. And then Dr. Zarro is also applying for a gastroenterology fellowship, and she will be talking to us about managing up, having completed part of the leadership pathway. So please welcome Dr. Luther.
Okay. Hi, everyone. I think most of you know me, but for those of you who don't, my name's Janki. I'm part of the Global Health Scholars Pathway, and so to represent my interest in public health, I wanted to give you guys a talk on Medicaid expansion. So here's an overview of my talk. We're going to take a deep dive into Medicaid, look at the effects of the Affordable Care Act on Medicaid expansion, focus on Medicaid in Missouri, understand the financing of Medicaid, and lastly, examine the barriers to enrollment in Missouri specifically. So Medicaid is implemented by the Centers for Medicare and Medicaid Services within the Department of Health and Human Services. It is the nation's public health insurance program for people with low income, and the vast majority of Medicaid enrollees lack access to other affordable health insurance. The Medicaid program covers 1 in 5 Americans and is the principal source of long-term care coverage for Americans. It also finances nearly a fifth of all personal health care spending in the US, providing significant financing for hospitals, community health centers, physicians, nursing homes, and jobs in the healthcare sector. Medicaid also covers a broad range of services to address the needs of the populations it serves. For example, as you can see, it covers prenatal care for pregnant women, in-home occupational and speech therapy for children with autism, and prescription drugs for those with HIV. Unlike commercial health insurance and Medicare, Medicaid also covers long-term care, including nursing homes and community-based services. More than half of all Medicaid spending for long-term care is now for services provided in the home or in the community that enable seniors and people with disabilities to live independently rather than in institutions. Medicaid also plays an important role in addressing the opioid epidemic and more broadly in connecting Medicaid beneficiaries to behavioral health services. As shown in the top right corner, Medicaid allows pharmacies to dispense naloxone without prior authorization. In the bottom left, you'll see that it covers at least 2, if not 3 medications for opioid use disorder and covers a range of treatment options like inpatient or outpatient detox programs. In the bottom right, you'll see that adults with opioid use disorder and Medicaid are more likely than any other adults to receive treatment for their addiction. So this slide shows some of the impacts of Medicaid as shown by prior research. It has been shown that Medicaid expansion leads to fewer hospital closures and better financial margins, more access to primary care and prescription drugs, and lower infant cardiovascular and cancer mortality. Additionally, the largest impacts seem to be in racial and ethnic minorities and in rural areas. There's mixed evidence for healthcare utilization, and including ED visits and hospitalizations, and moderate evidence for better self-reported health. Okay, so this figure has a lot, but Medicaid was first signed into law in 1965 by President Lyndon B. Johnson. This figure shows some of the milestones throughout the history of Medicaid. And while I would love to focus on each of them, we are going to direct our efforts on this section when the ACA was enacted. So when the ACA, also known informally as Obamacare, was initially implemented, it was supposed to be mandatory expansion of Medicaid to non-elderly adults with income levels below 138% of the federal poverty line. I want you to keep that number in mind as we move on, as it will become increasingly important. But essentially, the ACA said it would only fund Medicaid if states chose to expand coverage. However, in 2012, the Supreme Court said that the government could not withhold funding for all of Medicaid if states chose not to adopt expansion, but it could only withhold funding for the expansion portion of Medicaid, essentially making it optional for states. So here I have two figures showing the income eligibility for Medicaid in 2012 as a percent of the federal poverty level before Medicaid was expanded. There are separate income criteria for children and pregnant women, but I'm going to focus on childless adults and parents as it is most relevant for us as internal medicine doctors. If you look at the key below the figures, dark blue is the highest income eligibility and light blue is the lowest. As you can see, the eligibility varies drastically between childless adults and parents. The median income eligibility for Medicaid in 2012 for childless adults was 0% of the federal poverty level. And for parents, based on a family of 3, it was 63% of the federal poverty level. Now, for reference, I wanted to show you what these annual income limits would look like for parents and childless adults in 2012. The annual income needed in 2012 to be at 100% of the federal poverty level for a family of 3 was about $19,000. However, in order to qualify for Medicaid, they could make no more than $12,000 a year. For a childless individual, the annual income to be at 100% of the federal poverty level was around $11,000, but they were not eligible for Medicaid, period. So to address this, in January 2014, 26 states, including DC, finally adopted Medicaid expansion, increasing eligibility to 138% of the federal poverty level for both parents and childless adults, which was a huge improvement in coverage. In the 25 states that did not expand, the median eligibility for parents was just 47% and essentially still 0 for childless adults, which left millions of people in the coverage gap. So you might be wondering what the coverage gap is, and this figure kind of illustrates that for us. So on the left side, it shows childless adults and parents covered by the limited state-specific Medicaid eligibility guidelines. On the right, it shows individuals who are above 100% of the federal poverty line and qualify for premium tax credits to purchase coverage through the new ACA marketplaces. Everyone else in the middle falls into the coverage gap because they earn too much to qualify under their state's Medicaid eligibility guidelines and too little to qualify for marketplace subsidies. Those in the gap lack access to affordable health insurance. These figures illustrate the distribution of adults in the coverage gap in 2015, which was about 4 million people who lacked access to affordable health care. On the left, the coverage gap is broken down by state, and on the right, it's broken down by region. You'll notice that the South accounts for most of the coverage gap, as these states are the ones that did not expand Medicaid in 2014. And this is just a reminder again of the eligibility criteria in 2014, where you'll see many of those southern states that had very limited Medicaid eligibility. You'll also see Missouri, who was still not covering childless adults, and we're only covering parents at 16 to 38% of the federal poverty line. So let's dive into that a little bit more. As you may know, Missouri did not expand Medicaid initially in 2014. Prior to expansion, childless adults were not eligible for Medicaid in Missouri, regardless of how low their income was. Parents with dependent children were only eligible with incomes that didn't exceed about 20% of the federal poverty level. Only Texas and Alabama had lower eligibility caps at 18%. This left 127,000 people in the coverage gap. And you'll also notice in the figure that between January 2021 and January 2022, the eligibility limit does increase from 21% to 138%. So what happened? Well, in August 2020, voters in Missouri approved a Medicaid expansion ballot measure, and Medicaid expansion was set to take effect by July 1st, 2021. However, when state lawmakers passed the 2022 fiscal year budget, they did not include funding for the state's portion of Medicaid expansion. In June 2021, the circuit court ruled that Missouri's Medicaid expansion ballot measure was unconstitutional because it didn't include a funding mechanism. The case was appealed. The Missouri Supreme Court overturned the lower court's ruling in July 2021 and stated that Medicaid expansion criteria were now in effect. So essentially, after a lot of back and forth, Medicaid expansion was approved in Missouri. You'll see here the updated eligibility criteria, which now allows for coverage of significantly more adults. So far, we had talked about parents and childless adults who both now qualify at 138% of the federal poverty level. You'll also notice that infants under 1 are eligible if household income is up to 196% of the federal poverty level. Children 1 through 18, if their household income is up to 150% of the federal poverty level, and pregnant women if household income is up to 196% of the federal poverty level. Children above the Medicaid income thresholds whose families still cannot afford private health insurance are also eligible for CHIP, which is the Children's Health Insurance Program, if their household incomes are up to 300% of the federal poverty level. There are approximately 275,000 individuals who are now eligible for coverage after expansion. So this is data from our Center for Health Economics and Policy that show the expected demographics of new Medicaid enrollees after expansion. Roughly 3/5 of the new adult Medicaid enrollees will be previously uninsured. About 1/3 will be moving from private individual insurance coverage, including those in ACA marketplace plans, and about 10% will drop employer-sponsored coverage to move to Medicaid coverage. 2/5 of newly enrolled adult Medicaid recipients will live in rural areas in Missouri, compared to only 32% of the state's overall population, which, as you can see, there will be a disproportionate benefit in rural Missouri. About 1/4 of the new adult Medicaid enrollees will have incomes below 25% of the federal poverty line, and almost half of the new eligibles will have incomes above 75% of the federal poverty line. And that's partly because they're more likely to be employed. And finally, roughly half of the new adult enrollees will be under 35 years old, but about 20% of the new enrollees will be approaching retirement. So all of this is wonderful and all, but you might be wondering how it is funded, because everything in healthcare kind of rests on the money. So the government pays a share of program costs for enrollees prior to expansion, which varies by state. This chart shows what portion of Medicaid costs for people who are eligible for Medicaid prior to expansion are covered by the federal government. As you can see, in Missouri, the federal government covers 60 to 70% of the cost for people who are eligible for Medicaid prior to expansion. However, the federal government wanted to incentivize states to expand the number of Medicaid enrollees. So between 2014 and 2016, after the ACA was enacted, the federal government paid 100% of the costs for Medicaid for new enrollees. Since 2017, that federal share has gradually gone down. So now, as of 2022, they cover 90% of the costs for those that are newly eligible. And with this coverage, Medicaid is the largest single source of federal funds for states, accounting for more than half of all federal funds in fiscal year 2019. This figure shows the projected costs to the state with and without Medicaid expansion. An analysis by our Center for Health Economics and Policy at WashU demonstrated that expansion of Medicaid in Missouri would be close to net neutral and could actually save $39 million. If we had expanded prior to 2016, when the federal matching rate was 100% for those that were newly eligible for Medicaid after expansion, we probably would have received even more federal funding as a state. These projected savings are from that federal match rate, so 90% for new enrollees currently versus 65% for those who are eligible prior. All right, so now that we've established how Missouri will get paid and what we think the demographics of the new enrollees would look like, we have to move on to what's actually happening in Missouri. Oklahoma and Missouri both voted to expand Medicaid around the same time. There are about 215,000 people eligible in Oklahoma, and as mentioned before, about 275,000 people eligible in Missouri. Oklahoma had enrolled over 210,000 people, while Missouri had enrolled less than 20,000 people around December 2021. First, there was the delay in implementing it once it was approved, as we already talked about. But now, as shown by data in the Center for Health Economics and Policy, there are also delays in processing applications. This figure shows the cumulative number of Medicaid applications in Missouri since October 2021. While around 200,000 people have applied for Medicaid, around 64,000 of these remain pending at the end of April 2022. And the average delay in processing these applications was around 101 days. This delay has garnered a fair amount of media attention. The first article is titled, "Federal Government Steps In to Help Pull Missouri Out of Medicaid Backlog." Prior to expansion, average processing time for Medicaid applications in June 2021 was 8 days. It's now up to 115 days. CMS normally does not step in to help states, but Missouri is falling short, and our processing times are more than double what the federal government allows. CMS has published a summary of all the strategies that might help Missouri increase processing times, like increasing the number of staff and trying to remove duplicate applications that have been submitted. Delays in processing aren't the only thing that we need to think about. As you can see here, the Missouri Senate Committee had approved a bill that would let lawmakers decide year to year whether the state would have to offer Medicaid to working age adults. If approved in the Senate, the measure would appear on an election ballot. I looked last week, and as of now, it still says sent to Senate online, so we'll have to see what happens. In the same vein, there's a proposed amendment that would require clients to work or be in job training at least 80 hours per week, or 80 hours of community service in order to qualify for Medicaid. This could mean that people who are eligible one year might lose coverage the following year if they lose their jobs. So this, after all of that, this is the current status of Medicaid expansion as of March 2022. You'll see in dark blue the states that have not expanded. And for those states, here are the eligibility criteria as a percent of federal poverty level. You'll see that most of these states are still pretty low. And as mentioned before, look at Alabama and Texas. To remind you, here's the current annual salary at 100% of the federal poverty level for a 3-person family and for other adults in 2022. There's definitely progress since 2012, but still a ways to go. So some take-home points. Medicaid covers 1 in 5 Americans with low income and has a significant public health impact. 38 states have expanded Medicaid to cover childless adults who make up to 138% of the federal poverty level. In Missouri, this will provide coverage to around 275,000 adults and will improve access to primary care, mental health resources, and more. Here are my references. And I just wanted to thank you guys all so much for your attention. I know this is a dense topic, but I think it's important for us to know. Also wanted to thank Dr. Costco, the medicine chiefs, for giving me the opportunity to give this talk. Dr. Joint Maddox, who's been my research mentor for the last couple of years and who also is kind of an expert in public health. And then Dr. Matar as part of my global health pathway. So thank you. And I know we'll take questions after Sammy's talk.
Hey, hi, everybody. I'm going to take a sharp left turn. So sorry about that. My name's Sammy. I'm a 3rd year in the leadership pathway, and the leadership pathway is new to WashU. So I wanted to talk a little bit about it before I dive into kind of an example of what we learned and how to manage up. So I know you're all shocked, but I have no financial disclosures. Okay, so physicians are inherently leaders. I know that's not surprising to you all who are physicians, but it is kind of interesting if you think about the vast knowledge we cover in medical school and in our training, but really none of the hard or soft skills, like how to be a leader, how to be emotionally intelligent, how to communicate were a part of your medical school training, or if you were lucky, maybe they were a small part. And now a lot of programs, residency programs, are starting to incorporate this, but it's really not the standard. And I'm sure you guys all realize that we lead care teams, we lead patients, we lead groups, but we also, many of us elect to go on to higher levels of leadership and without really any guidance. So in 2018, the Harvard Business Review posted this article kind of talking about the lack thereof and encouraging more training programs to incorporate leadership skills. So the leadership pathway is a way for these residents who want to kind of step foot into that leadership realm or have really taken note of this to gain more of those skills. So the pathway was created for these residents, like I was saying, that the ones that really wanted or had an interest in learning about leadership in academic medicine. And it really wanted to propel those residents into this career in a couple of different ways. One was to provide this concrete distinction on their CVs for their next steps in their journey, so that the next, whether it's fellowship or a job, know that that interest exists for that resident. And then also to provide this training, these skill sets, this launch pad into academic leadership. So the pathway is structured over 2 years. In the second and third year of residency, it encompasses many aspects in those 2 years. The first part is a career exploration. So this is when we get to meet in these small group settings with different leaders in BJC and BJH and really ask them about how they got to their position, what they like, what they don't like, what their day looks like, and any advice they have for us. Most of our training comes in a 2-week didactic block in February of each year. In this, we do guided courses through the BJC Institute for Learning and Development. We do workshops and discussion boards and we break down all of these topics as a discussion together. And then we do a lot of literature review and independent reading on different leadership topics. And then lastly, over the 2 years, we're involved in the institution throughout different committees to kind of see this leadership in day-to-day in real life and get to know what BJC leaders are doing month to month. So who are we and what did we do last year? We're led by Dr. Maureen Lyons. She's our fearless leader. And then during our 2-week didactic block, we also did a lot of work with Dr. Russell Hoffman, who's the VP of Organizational Development and Culture at BJC. They really guided us through. Also, special shout out to Dr. Abby Spencer, who actually gave a talk on managing up during those 2 weeks. The 6 of us included 2 third years that were the first graduates of the program, Luis Hernandez and Josh Newman, and then David Leander, myself, Michael Veshkini, and Nirul Patel. The 6 of us got to sit down with Rich Leiwig, who I'm sure you all know is everyone's boss, the CEO, and then Katie Henderson, who's the CMO of BJH, which they kind of walked us through what their life looks like. It was very informative and really great. So what did we learn? Well, we really kind of, like I said, we dove into what does a leader do? What skills do they need to have? What are examples of good and bad leaders? And then after we kind of talked about it at a bird's eye view, we really dove into a lot of these topics. So emotional intelligence, self-regulation. You can't really lead others if you really don't regulate yourself and know how people's emotions, how to recognize emotions in other people and work with them. Interpersonal communication. Of course, communication is a huge part of leadership, and learning how to communicate effectively is number one. Conflict management and mediation goes without being said. A big part of being a leader is getting in the middle of messes, developing others, working on feedback and how to build a team effectively. The team environment and psychological safety. I'm sure you guys have heard that phrase a lot lately. It's becoming kind of a buzzword in medicine, and I think with good reason. It was definitely stolen from the business world, and it's all about making the environment safe and open, that people can speak up and feel like their voice is heard. And before I dive into managing up, which is what we'll talk about more today, I want you guys to sit back and think about the worst boss you ever had. It could be your shift manager at a Chili's when you were 16, or maybe it was the worst attending you had during medical school that made you feel that big, or maybe it's one now. We won't have to say that out loud. Or maybe you've never had a bad boss and you can relate to some of these terrible bosses in pop culture. But something, if you really think about it, that all of these bosses have in common is they really work in kind of a top-down approach. They manage down the chain, and this really leaves no room for others' opinions or kind of taking ownership in your work environment, and can ultimately lead in disengagement or all of your 16-year-old busboys quitting your Chili's. So what managing up allows you to do is, as an employee or as the person that doesn't hold the power, it really feels like you have a decision, you have a choice in your workplace, and you're actually changing things. and it allows you to have a voice that actually affects change instead of a voice that's just heard. So what is it? The Harvard Business Review defines managing up as being the most effective employee you can be, creating value for your boss and your company. Well, that's super vague and kind of annoying. It doesn't really define anything, or it didn't really for me. But after reading a lot about managing up, it really makes sense that this is vague, because if you break it down, it really just boils down to how effectively you can get what you need out of that relationship when you're not the one that holds the power or has the final say. So that can be applied in a lot of different directions and ways, but we'll kind of talk about a specific way you can start anyway today. But what it is not is it's not manipulation. It's not a win-lose or compromise. It's collaboration and working as a team with your employer or boss or whoever that person is that holds the power. So just like psychological safety is becoming a buzzword, managing up is becoming a buzzword in healthcare as well. If you do a quick search with those two phrases into Google, there's many articles that pop up. These are just some examples I found. The top one is from Vanderbilt's website. They have a whole section on their website for their employees on how to manage up, what it is, and how it improves teamwork. The next one down is actually from a travel nursing website about how to manage up and use it effectively as you go from healthcare system to healthcare system. And then the last one is actually an article that was published in 2010 that's talking about managing up and how it improves time in the OR. So I think it'll be something that you guys hear more and more. So how do you do it? This is kind of my quick and dirty way of thinking about it. So really it starts by, like I said, it's teamwork at the end of the day. You have to align your goals with the person that you're making the ask to. So you have to find common ground. The next step is no problem can be solved if no one is aware of the problem. So you got to identify it. You got to identify it eloquently that doesn't point blame or point fingers at anyone. And then lastly, you want to provide a solution that works for that particular leader or coworker or person of power. That is definitely the most important part. And we'll talk more about it. So why and where can we manage up in healthcare? Everyone knows that, I'm sure all of you are well aware that we have a million bosses, especially in academic medicine with our natural hierarchy. As a med student, it's very apparent, but even no matter how high you up are in this pyramid, there's a ton of bosses ahead of you. So those are the more traditional roles. But also those who hold money hold power. So really you can use this in any situation where you have an ask of any kind. And a lot of academic medicine is where's the money coming from? How can I get money? How can I give my residents more lunches? How can I get more money for my project, my team, my research? And so this is a skill set you can definitely use in that area as well. But there's also less traditional bosses, and Harvard Business Review calls this managing across, and really this can be used of anyone who has something or you need something from. So case managers, patients, nursing managers, we all fight for the same resources sometimes. And so this can be used there. It can also be used to make your team more effective in patient care. And I know everyone looks at a slice of Swiss cheese and thinks of patient safety like I do. So really being an efficient team is what makes patients safe. And so this can be used there as well. So things to consider. So this is really where it becomes like the tips to make this work for you. So there's a lot of different ways, like I said, I've already alluded to this multiple times, but this is just kind of an outline, a way to start. But the most important thing out of all of this is you have to get to know your leader. This doesn't work. You can't generically just go up to someone and ask the same question in the same way and expect the same answer. So this doesn't mean you have to be best friends with your boss. You don't have to go out to dinner with them, but it does mean you have to get to know how they like information. Do they like emails? Do they like face-to-face? Are they one-on-one people? Are they let's get it all done in a meeting on a Friday kind of people? Do they like to be the person that you give them one specific solution and they just get to say yes? Or are they a person that likes to have the final say and you need to give them two options? These are all really easy to pick up on if you're looking for them. And if you're, especially if you take time to think about the way things have gone well or not gone well for you with your leader in the past. Be specific and be the solution. I also alluded to this earlier, but the best way to not get what you want out of a situation is to leave it open for someone else to have the final say. So like I talked about, it might have to be tailored to your leader in order to get them to get what you want, but you should be okay with every outcome that you're offering. So that's the way to spin it successfully in order to get the best situation out of it. be genuine, be specific, be reliable and be respectful. Those all kind of go together, but it should go unsaid. You have to be a good employee and a good person for people to want to do things for you. But it bears, mentioning again that nobody wants to work with the employee that's not giving them what they need at the end of the day and is not a good person that they want to work with. And then leaving your assumptions at the door. You really want to go into it not expecting much, but knowing that maybe in the past they did not give you what you wanted in this session. Did they not give someone else what the outcome that they wanted? But that they, if you think about it, if you tailor it to them, if you've really considered their viewpoint on the situation, then things might go differently this time, and you want to be open to that. Okay, so let's walk through an example. I know this never happens at WashU, so let's just pretend we're somewhere else, but you're a really, really hungry, really, really tired intern on MedFirm, and your well-intentioned attending is just educating you over and over in every patient room. So rounds are going well past 1 o'clock. You've never made it to a noon conference on time and you're not getting lunch. What are you going to do? You're an intern, right? You don't have any say in the way the team goes. You don't have any say in getting to lunch on time. You're just kind of grinning, bearing it, and your senior's not helping you out. So what can you do? How can you manage up in this situation? Well, first, you got to align your goals. So this attending clearly loves education, right? They're spending way more time with you than they need to. They're spitting a lot of hot air to try to get you to learn things about these patients. So there you go. You also really want to get to educational time. You want to learn more too. So there you found some common ground. Second step is the attending might not know. So you have to communicate the problem, but you also have to communicate a problem in a way that's going to not offend them, is presented very respectfully. And then last step is you want to be okay with every outcome. So you want to give them specific solutions that you think that they'll gravitate towards. So rounds are a perfect example of really getting to know your leader. You know how they like to make decisions, how they like how they like discussions to go, how they talk to patients, and how they are happy or sad with outcomes depending on what happens. So you've seen them make a lot of decisions, even if you've only been around them for 2 days. So maybe they're an attending that really likes you to have a well thought out plan that they can just say yes or no to. So you need to provide them one solution and you think that's going to work for them. So this is an example that I came up with. Hey, Dr. So-and-so, I've seen how much you prioritize our education, and I've noticed that we've been rounding well into noon conference daily. I was thinking of ways to be more efficient on rounds in order to make it to our conference regularly, such as we only talk about educational topics on 3 patients that day, or whatever your team has liked. And this is a spot where I would really pull in like my chief or my senior resident and ask them before I approach them. But breaks it down. It provides each spot. You've pointed out that, education is important. You want to get to education and you want to make rounds more efficient to get us there. So there's a lot on this topic. There's not a lot in healthcare specifically. So I tried to make an example that we can all relate to, but Harvard Business Review has a ton out there on it. This is their paperback book that has tips on how to manage up and manage across. Though it's not healthcare specific, we're all employees at the end of the day, and a lot of the examples you can definitely relate to. So I encourage you, if you're interested in it, to check it out. It's very cheap. It's on Amazon. There's also this QR code is a podcast that Harvard Business Review puts out. And if you scroll down to the bottom of the links page, there's also links to different Harvard Business Review articles about it. It's very interesting. There's also a lot out there about women and how to manage up specifically for women. And I think women in healthcare and women in medicine groups often talk about this and how to get what you want, how to negotiate. And I think that this gives a lot of really interesting and like a good perspective on it for sure. So what's on the horizon for us next year? Dr. Lyons is unfortunately going to Oregon, but we're very excited to welcome Leica and RJ to the pathway this year. And we're excited to get down to February and learn more about leadership. And thank you guys. I want to thank all of you who came today and my fellow leadership pathway friends, Dr. Lyons, Dr. Costco, Dr. Frazier, the chiefs for letting us do this, and all the house staff friends. So happy to take questions. No. Cool. Okay.
It was too good, too clear.
I guess so.
Okay. Oh, wait, we have one question.
This question for Janki. So you mentioned earlier that the Missouri Senate or Missouri state did not pass expansion, like actually fund the expansion of Medicaid. Is that the reason why Medicaid's been delayed over the last year?
Yep, exactly. Yeah, they didn't allocate funding for it. And so that kind of delayed the whole thing because it had to go back and forth between like the circuit court and the Missouri Supreme Court. So that was one of the big delays.
Gotcha. Is there any other big consequences of that lack of funding?
Now it's taking forever to process applications. And so like I had a patient yesterday in clinic who told me that he was quoted at a time of like 6 months for his Medicaid to be approved. So yeah, I think that's partly because the delay in funding and also now just there's like not enough staff to process this influx of applications.
Sure.
Sorry, yeah, one other question. So what kind of gap are we gonna be left in Missouri then in terms of uninsured if we cover these 275,000 people? And then are there other states that are looking at various ways to kind of provide coverage?
Yeah, I think other states are starting to think about Medicaid expansion. In Missouri specifically, I think this is a big improvement for childless adults and parents, but then there's also pregnant women who will qualify up to a certain level while they're pregnant. And then once they deliver, the eligibility criteria change essentially because they go from being a pregnant woman to a parent. And so those levels drop. And so then there's a gap in coverage there as well. And so some states are looking to extend it for like 6 months to a year after delivery so that these women get coverage in the postpartum period. So I think that's probably something that we could look at as a state and also other states could start looking at.
Yeah, Dr. Green.
Those were both terrific talks. Thank you both very much. I have a question for each of you.
Okay.
So to start with the leadership question.
Yes, ma'am.
Are there, it sounds like a great program and I'm really glad that you're participating. Are there specific aspects of leadership that you think we should build into the standard curriculum for all of the residents?
Yes.
So what would you recommend?
Yeah, we do a couple already, which I think are fantastic. I know Dr. Strzelski does one with us as you start second year, kind of learning what your color is. So what your kind of leadership style would be. And I think EQ and talking about psychological safety, so getting to know how to recognize emotions in others, that definitely has overlap to patient care. And there's kind of a lot of the leadership skills that are overlapped into like motivational interviewing, which we also do skills in, but also getting to know your leadership style and getting to know where your deficits are is really important, and getting to know how to recognize that in others as well. So I think we kind of do it. We just don't have as much time right now as obviously we could, but there's so many things to cover.
That's great, thank you.
Mhm.
And in terms of expanding Medicaid, you mentioned, there are government leaders are trying to enforce, that people have to work. I think there was a little bit of a typo in that they want people to work 80 hours a month, not 80 hours a week.
Sorry, yes, 80 hours a month.
I was like, that's worse than us.
I was just thinking of our work schedule. Yeah.
But, and I'm not in favor of that at all. I think that's a terrible idea of making folks work, but, though I do like work. So for us as physicians caring for underserved patients and Medicaid patients, are there things that you think we need to know in terms of how to manage costs and healthcare more effectively in terms of optimizing care for these patients with very restricted finances?
Yeah, I think we sort of get some of this in clinic when we try to like send patients to physical therapy or other specialists or even prescribe certain things. We'll get a call back and like, this is not covered by Medicaid. So I think, if potentially at the beginning of intern year, before we start, we get a little bit of education on what is and is not covered by Medicaid, it probably would make the care more efficient in terms of getting patients what they need. So I will say it's extremely difficult because there's so many different types of insurance and there's no way to know what people will cover and what they will not, like lidocaine 4% versus 5%. Doesn't matter, but it does to insurance companies. So it's really hard, but I wish that we had a way to easily find that information. Maybe if there was like a centralized website or something that we could go and just say, hey, what does this insurance company cover? That probably would help out our patients.
Thank you.
Yeah.
Dr. Prater?
There's another question.
Thank you both for wonderful talks. My question is for Dr. Luther. So this might be outside of what you researched, but we're now approaching about a decade of Medicaid expansion in many states.
Yeah.
Is there some type of organized effort to collect data and indicators that might drive future decisions? Perhaps not that lawmakers will care about, but certainly the individuals that it would affect. Is there anything that you know of?
I know that there's state-specific things. So I know Missouri is doing it through the Center for Health Economics and Policy. I don't know about a national organization that's doing it for the entire country and looking at all the states that have expanded. But I know like Oregon has one, we have one. I know Massachusetts has one. So it would be great if we could get all the states to like pool their data together, but I'm not sure if something like that exists yet.
Okay, well, thank you all very, very much. I think these two talks actually set the stage perfectly for what's coming up in the next few weeks. We have Dr. Kevin O'Leary coming next week, kind of to build on leadership and talk more about kind of leadership in medicine. And then we have a few talks on healthcare policy in the next 2 months or so. So next week, please join us over in the Holden Auditorium in the med school as we continue grand rounds. But thank you, Janki and Sammy.